if you need this information, you've got the information. I will send it as a link to you. So you'll have this information for study or whatever you need it for, okay? So I will get that done. It takes a little while to download, and then I'll upload it for you. Probably tomorrow, probably not today. And tomorrow, I presume we'll be back on campus as well. So you'll have funds, and I'll be there, and that'll be good. So today, what I thought we would do, I've got a few things I want to do with you, is I want to go over 6 chapters, and that's a lot of chapters. But the way I'm going to do it, and what I'm going to do, guys, I'm going to ask you all to mute.
Hey, how are you? Might speak to
Can you mute whoever it is? I'm going to have to. Let me mute you all. Let me see if I can mute you all. Which isn't what I want to do, but I know there's a way, and I just can't remember how to do it. Oh, well, good. You're all muted right now. Okay. So a lot of you asked about the quiz. So a couple of things. I'm going to see if maybe there's some time tomorrow to do. That's probably what you're... You know, you can always put stuff in the chat, by the way. I've got the chat thing up, so if you need to, you can always contact me that way, okay, via the chat. All right, Thursday quiz. I'm going to try and see if we can do it Thursday. If not, we'll do it on Monday. So either tomorrow or Monday, one or the other, whichever one works. So we'll do that. I'd like to see if we could do it tomorrow, but I'm not sure you know what is scheduled tomorrow, so we'll play that by ear. So what I want to do today is I do want to go over these 6 chapters. I also want to do a little bit of prep as well for your exam that's coming up next week, okay? So we'll go over the exam. Now, the first thing I just want to pull up for you is if you pull your syllabus, and let's see if I can screen share what I want to show you. I am not on campus. Okay. All right. Let me just do this. So I'm just going to screen share something I want to show you. Okay. Can you all see the syllabus up? Can you see the syllabus? Anybody? Anybody?
Yes.
Thank you.
Yes, we can.
Yes.
You have to participate because I can't tell what you can see, what you can't.
I can't see the chat.
You can't see this syllabus?
No, I see your syllabus, but the chat, no.
Okay, but you can see the syllabus. That's what I'm asking. So under the syllabus, what I want to show you is this. It's page 5 onwards, and it says outline of main topics. And you might find that this is just like a little cheat sheet study guide type of thing of the main things that you need to know in order to take your exams, okay? So, you know, this is the sort of categories that we predominantly look at. And I just wanted to show you that. As I say, you might find that a helpful little guide on some aspects that you can then plug in other things that you could, you know, cut and paste or whatever. So page 5 through page 6 just gives you an outline of the main topic. So I did want to just let you see that, just as a suggestion. Okay. All right, let me turn. I don't know why it keeps turning my camera off. That's really strange. So, that's that. I'm going to hide that. I can cancel that. Let me pull up what I want to pull up. Takes a minute. Come on. Okay. So what I've done is a lot of case studies that I figured we could go through, and I don't know if we'll get through it all, but we'll try it. If we don't, we can always do a little bit tomorrow as well. So we'll just play it by ear, okay? What I've done as well is I looked at the HESI, the Farm HESI exam, like the last one and the one before, and I've pulled out the medications that are pertinent to cardiology that have shown up on the HESI. So what I'm doing today is each of these chapters we're going to have a look at. And I'm sorry if I'm going to have to look down a little bit. I don't like having to do that, but it's a little awkward the way I've got the setup here. So we're going to start in chapter 22, which is antihypertensives, okay? So we're going to go to antihypertensives. And we've talked a little bit about antihypertensives. And first of all, I want you to just be aware that we've got different types, haven't we? We've got ones that end in pril. We've got ones that end in sartan. We've got ones that end in denied, or penes rather. And we've got ones that end in ides. And if you sort of just see those endings, that might clue you in a little bit that these are antihypertensives one way or another. So I'm just going to go on, if you have your books, a couple of things I want to bring out, and this has been on the HESI before, and the things that I'm bringing out are things that have been on exam questions, quiz questions, and that's why I'm talking about them. So on page 335 of your books, there's a piece that talks about JNC8. And really what this is a group of professionals, physicians that got together and made a decision on what high blood pressure should look like and what normal blood pressure should look like. And what they say is hypertension or high blood pressure is a systolic blood pressure greater than 150 and a diastolic greater than 90. Jabria, you're late. Now I've got to get course key back up. Hang on. All right. Hang on a minute. Sorry, guys. Jabria, are you there, Jabria? Jabria? I just see you I saw you. Can you please clock in? Jabria, I need you to clock in, please. Otherwise you'll be marked as absent. I don't know what she's... Did she clock in? Does anybody know Jabria? Anybody?
No.
Are you Jabria?
Zori says she's gonna try to call her.
I saw her try to clock in. Oh, it's Mercedes, right?
Yes, ma'am.
Hi. Nice to see you. Okay. All right. Well, I'm going to leave that up for a second. It turns my camera off, but I'll leave that up for a minute and hopefully she'll clock in. All right. So JNC8 basically says there's certain parameters for high blood pressure, and it's on page 334. So it says basically 150/90, and that's for patients that are older than 60, or it's 140/90 for patients that are younger than 60 but have chronic diseases such as diabetes or kidney disease. So there's two different parameters there. It's not just 140/90. I want you to be aware of that because that sometimes comes up. Okay, that's one of the things that can come up on an exam. And as you can see on page 335, there's different categories of antihypertensive meds. And there's a few of them that are shown there. And we're going to go over some of them today. On page 337, there's a picture of the brain. And it just has different areas of anatomy, and it just shows you the different types of blood pressure medications and what works where or what has a connection to what. So I just want you to be aware of that as well. Let me see. Bear with me a minute. I gotta see if this person clocked in. I can't.
I called Jabria and she's having trouble logging in. It won't let her log in. That's why she keep going in and out. But I removed her from the meeting so she could re-click the link. But that's what's going on.
Okay, let me see if she. All right, I'll leave this up for a minute. Can you also, is that still screen shared for you or not? No? Yeah, I think it is. The session code?
No.
No, it's not. All right. Let's see. These are the reasons that I'm not keen on this type of thing. All right, that should be there. All right. So anyway, you can see, all right, so we've got different types of antihypertensives. So we have certain ones that are alpha blockers, we've got beta blockers, we've got ACE inhibitors, we've got a lot of different ones. The one I want to start with is what's called an ACE inhibitor. And if we go to page 340, it talks about ACE inhibitors. And ACE inhibitors basically are the first line med that gets used as an antihypertensive. And what do these ACE inhibitors do? Well, what they do, Jabria, are you in yet? I can't keep stopping the lecture. Okay, I don't know if she's in or not. What these ACE inhibitors do is basically stop an element, an enzyme called bradykinin, from being broken down. So this bradykinin builds up in our system, and it actually inhibits things like aldosterone. And it also inhibits things like sodium and water resorption. And both of those things can push the blood pressure up. So it actually helps to inhibit this renin-angiotensin aldosterone system. And so as a result of that, it actually lowers blood pressure. That's what we're doing by that. Now, a lot of people, when they take this medication, they get a side effect, which is a cough, right? Anybody remember the cough that happens with Prils? Anybody familiar with that at all or not? No.
Is it a dry cough?
A dry cough, exactly. Yep, a dry cough is what happens. So this dry cough occurs, and I'm actually going to pull something else up for you guys because I want to share something else, and I've lost you all. There you are. All right, so I'm having a hard time sharing what I want to share. Interesting. Give me a second here. Let me see if I can cancel this. I don't want this. I don't want this. I want this. All right. I want to screen share something with you guys. Okay. Can you all see this piece on antihypertensives that I've got up right here? No?
No.
Can you see it now?
Yeah.
Okay, perfect. Okay. So because we've only got a couple of hours, I really wanted to go over a couple of case studies first. All right. So this is a person, as you can see down here, he's 50 years old. He was given lisinopril. And his blood pressure, you know, has been controlled pretty well on that, right? 130/38, 80/84, not bad. But he's got this dry cough that happens. So when people have this dry cough that's driving them crazy, it's because of this bradykinin that's increasing in the body. And that's what the reason is for the dry cough, by the way. Now, there's other side effects as well that happens with this lisinopril medication that can occur. And it talks about, first of all, about what's going on with the dry cough. It's this bradykinin that's the problem. It builds up in the body. That's what leads to the chronic cough. The other thing I want you to be aware of, if somebody has a swelling of the mouth or swelling of the lips, it can be caused by what's called angioedema. And that is a obviously severe reaction to this lisinopril, and we would stop that immediately. The other part of the issue with some of these meds is hyperkalemia. That's another issue with this med. What is hyperkalemia? Anybody remember what that is?
Isn't that the inability to
Elevated potassium.
It's high potassium, exactly. And I want you to know your potassium levels, please, because I'm sure that that type of thing is going to come up, you know, on exams or HESI. So you need to know your potassium levels and you need to know your sodium levels, okay? The other thing that's a big side effect is hypotension. And what happens sometimes, and this is why I've put this men's health piece here. One of the side effects, actually, unfortunately, with antihypertensives is erectile dysfunction. And that's, you know, an issue. So here's the thing. You've got to be careful if men are using something like Viagra or sildenafil. These types of meds combined with an antihypertensive can actually cause severe hypotension. And I've put the page number there because it's in the aspect of men's health, but I'm letting you know this because it's shown up on a HESI. Okay? So I want you to be aware of sildenafil or those types of things, Viagra, those types of medication under men's health can actually cause severe hypotension, meaning they can get a very, very low blood pressure. So it is a contraindication, not an adverse effect. Okay, so if somebody is on something like this, then it's a contraindication. Okay, so all right, so lisinopril, we know it causes that cough. And let's see. The other thing I want you to be aware of is this is another thing that happens. Sometimes people can get infections with ACE inhibitors. And part of the problem is it reduces the white cell count. And do we remember what white cell counts do? What is a white
It
cell?
tells the body what's
It fight off infection.
It does, exactly. So if they've got low white cell count, that can be a problem. I don't know why I'm echoing. Yeah, thank you. It's probably a thing. All right. So as I say, on page 340, it talks about lisinopril, it talks about ACE inhibitors, and that's one of the biggies that you need to know. I'm just going to skip back a tiny bit because there's some other ones that I just want you to be aware of. And these are your alpha blockers. And you may remember that we talked about alpha blockers when it comes to things like benign prostate hypertrophy, those types of things, right? We talked about that with men's health. Hyplasia. I always say it's hyperplasia. I'm sorry. Benign prostate hyperplasia. So when the prostate is enlarged, those types of things, we use alpha blockers. Well, if you look on this little sheet that I've put here, that I've put up, one of the alpha blockers right here, doxazocin. This is actually shown up on a HESI as well, doxazocin. And so again, you have to be careful because if somebody is using it for BPH, but they're also on another type of anti-hypertensive med, they might not realize the correlation there. And again, they can get dizziness and their blood pressure can go too low. All right. So I do want you to be aware of these types of things that are going on here. All right, let's just scrolling on down. All right, so now we have another patient. This patient is a case study, and we're looking at a big drug that's used for blood pressure that we're going to talk about in a second. And this drug is on page, bear with me, because I'm jumping around a little bit. Let me find it for you. Oh yeah, at the bottom of 343. You're going to see a drug called sodium nitroprusside. Okay, so this is used IV, by the way. This is an IV drug that's utilized. And, you know, you're only going to see it in the ICUs, those types of environments. But the reason I want you to see it is because if we turn over and look at this drug, there's a few things that are concerning. And actually, it doesn't talk about it there. Where does it talk about it for me? It talks about it in detail on page 348, at the bottom of page 348. And you can just write that down for now if you want. So this is a continuous drip that's helping to smooth, to actually work on smooth muscles. So it's causing relaxation. So it's helping to reduce the blood pressure. Okay. And the reason it's important in this scenario is because the patient has had an abdominal aortic aneurysm that's been repaired. So we want to keep that blood pressure nice and low so that it doesn't blow that graft. All right. But there's some issues with this nitroprusside, or so if we look at it down at the bottom of page 384, right down the bottom, first of all, it's a potent vasodilator. So it's going to have a very, very strong effect on the blood pressure, first of all. So you could get severe blood pressure drop, and you could get ischemic injury. Now, the other thing I want you to be aware of is a couple of things. This only gets infused over 10 minutes. That's it. because of the risks with this particular medication. It's such a high risk of dropping the blood pressure and causing ischemia. The other thing is, if you see this medication, you may see it wrapped in tin foil, aluminium foil. This, if it's exposed to light, becomes cyanide. You think that might be a problem? Yeah, absolutely. Okay. So, you know, as I say, this is a really concerning medication, sodium nitroprusside, but I wanted you to be aware of this drug. It's sort of a big deal. Okay. So there's a couple of case studies here, as I say, that I just wanted to mention before we go on to angina meds. But there's a few other meds, and you're going to see these meds. I'm going to unshare my screen for a second. Hopefully, there we go. So, hi, I'm back. So you're going to see a few of these different meds that we talk about, like beta blockers, calcium channel blockers, not just used as antihypertensives, but used in different ways as well. They can be used for congestive heart failure. They can be used for different dysrhythmias. So you're going to see these names sort of sprinkled through all of these chapters. So let's just have a little look at some of them. I just mentioned the ACE inhibitors, and I also mentioned alpha blockers. Doxazocin is the alpha blocker that I just want you to be aware of, okay? And that one is on page 338. It's also known as Cardura. And as I say, it can be used for blood pressure or it can be used for BPH. But it's a great drug. But just as I say, the thing I want you to be aware about with doxazocin, and this might come up on a test, is that the matrix of this particular tablet or capsule, it's a capsule, gets expelled in the stool, okay? So the patient might say, oh my gosh, that medication isn't working. I saw it in my stool. And you're going to say, you're going to educate them and say, yeah, that's normal. It's okay. It's normal. All right. So I just want you to be aware of that. And it talks about that on page 339. Now, we did mention beta blockers the other day. So we went over that a little bit with the selective, cardioselective ones and the non-cardioselective beta blockers. Remember, we've got beta 1 heart, beta 2 lungs, right? So that's the difference between the cardioselective and the non-cardioselective. And if they're non-cardioselective beta blockers, remember you have to be concerned about your what type of patient.
Asthmatic.
Good job. Yep. Your asthmatics. Absolutely. So if it ends in a lull, you know it's a beta blocker. All right. And it's then just a case of figuring out which one it is. Now, a couple of other meds I just want to go through, and then we'll move on to the next chapter. ACE inhibitors, while they're a first-line med to be used as an antihypertensive, not all genetics are good with these meds. And actually, for Afro-Americans, ACE inhibitors are not your first-line med. It's going to be something like what we call a calcium channel blocker. And that's like your amlodipine. Remember I said if it's a calcium channel blocker, it ends in pine, right? Remember that? And let's just have a look at a couple of others as well. On page 341 down the bottom there, there's the angiotensin receptor blockers. Well, these are great because they don't actually cause that cough or angioedema. And the reason is they're working on what? A receptor. They're not actually doing anything with this enzyme, bradykinin. So they have a slightly different effect. And that's why, you know, if someone's having this cough, you could switch them to an ARB. Now, ARBs work really well, but the problem is with ARBs, ACE inhibitors work very well on the kidneys. And so they're often given to diabetics because of their effect on the kidney, on perfusion. ARBs Not so much. So, you know, that's why we're not so sure about the protective factor of the kidneys. So you're not going to see those used as much with your diabetics if it can be helped. All right. So I'm just bringing out some of these key points. But the big thing with an ACE, hyperkalemia, the dry cough, and angioedema. All right. Those are your biggies. All right. Let's see, what else do I want to talk about now? Calcium channel blockers. Well, calcium channel blockers, by the way, sometimes these meds get used for migraine headaches. So you might see somebody on a calcium channel blocker that is like amlodipine or something like that, something with a peen on the end, and they're not actually having a blood pressure issue, but they may have a migraine. And the reason is as well, what they're saying with the with migraines, they actually think it's some sort of vasoconstrictive issue that's going on. So with the migraines, there's some sort of they don't actually really know why migraines happen. There's lots of reasons, but that's one of the things that they think. So they think that the things like calcium channel blockers can work really well to help reduce migraine headaches. So just information there as well. Let's see. What these actually do is they block the binding of calcium to its receptors, and that's how it works with preventing contractions. Okay, that's how calcium channel blockers work. All right. So we just mentioned nitroprusside. And let's see what else I want to just quickly talk about with antihypertensive before we move on. So let's look at some of the assessment, right? There's a lot of things that you're going to assess your patients. I already talked about this JNC8 and just mentioned to you about JNC8, right? So the blood pressure 150/90 if they're over 60, or if they're younger than 60 but with chronic illnesses such as diabetes or renal acute kidney disease, something like that, then it's going to be 140/90. Can someone see if that works for her? All right. Other labs as well. So CBC, CMP, which is Comprehensive Metabolic Panel. Liver enzymes you're going to look at. You're going to look at your kidney function, of course. Be aware as well, if somebody's had an MI, a heart attack, then we are actually going to look at some other enzymes as well. We might look at cardiac enzymes. We might look at certain things that look at sedimentation rate, which looks at more inflammatory panels, things like that. Cardiac enzymes are also known, by the way, as troponins, and you'll get into that a bit more. But anyway, I just wanted to bring out some of these points. You're going to evaluate your patient, aren't you? All of the different signs and symptoms of hypertension. What does hypertension affect? Any idea? On page 345, it gives you a big long list of the different things that can cause hypertension, by the way.
Obesity, nicotine use.
Yeah, that's a big issue, right? That could be an issue.
What page?
Yeah.
345.
When you said
345, let me put it in the chat.
when you said assessment for hypertensive, you said CMP or did you say BMP?
Well, it could be either comprehensive or basic. But anyway, there's lots of reasons that blood pressure can go up, right? Additional look at coronary artery disease, family history, smoking. So we're going to take a health history, and then we're also going to look at the patient as well and ask them a lot of questions, you know, about what's going on with them, and have an idea of what might be happening to them with their blood pressure. Okay, are they checking it at home, for instance? Have they ever been on any blood pressure medications before? If so, which one? Oh, I was on an ACE inhibitor and it made my lips swell up. Well, we know that we don't want them on that again, right? Those types of things we're going to take into effect. We're going to assess their heart rate, going to listen to the apical pulse, going to make sure they don't have that dry hacking cough, okay? By the way, on page 346, there's a little pink square thing, and it just says, again, about cultural implications. Asian populations as well don't do particularly well with ACE inhibitors. They do better with calcium channel blockers and also diuretics, which we'll talk about another week. So again, it's important to recognize all of these pieces. What are we going to teach the patient? What types of things? Well, don't get up too fast, right? You don't want them getting up too quickly, especially if they're on other medications that could also interact with that. So lots of patient teaching. Be aware as well about the beta blockers, like I've told you before, right down the bottom of page 347. So some of the things that I've been talking about, I'm just reiterating over again. Let's see. Potassium levels. Now, this is a big deal. And the reason I'm bringing this out is because it's been on a HESI. All right. Looking at the potassium. Let's see. Look at it right here. Potassium levels can rise with the with things like lisinopril, ACE inhibitors. Okay. Beta blockers, by the way. Beta blockers have been on the HESI as well. Labetalol. Now, we may not have gone over that exact medication, but you're going to know it's a beta blocker, right? How are you going to know that?
LOL.
Thank you. LOL on the end. That's how you're going to know about it, right? And so with beta blockers, sometimes these medications get used as well for congestive heart failure. Now, remember with congestive heart failure, and we haven't talked about it that much, we're going to, but remember about weight gain. People that have congestive heart failure have extra fluid on board, remember? So what do we have to teach them? Weight gain. We always say how much in 1 week and how much in 1 day weight can they, what's the issue with the weight? Remember, if it's
No more than 2 pounds in a day, and then no more than 5 pounds in a week.
you got it. Yes, that's the teaching, right? So this is the type of thing that if they're on a beta blocker like labetalol and it's for congestive heart failure, the question might ask something along the lines of, what's the patient teaching? Well, it could be making sure that they understand about the weight gain. All right, does that make sense? Yeah. And as I say, unfortunately with HESIs, I don't know what they ask. I actually don't know the questions, but I at least can give you some guidelines. So anyway, that's something to be aware of. Let's see what else I want to talk about. Creatinine. Creatinine is a lab value to do with kidney function. So, you know, that's important, right? That's important because obviously if the kidneys are not functioning properly, remember I talked about very briefly that renin angiotensin aldosterone system. It's called the RAS system. And that's really to do with the kidneys. So if the kidneys are not working properly, then some of these medications might not work properly. And also we need to look at that kidney function to see whether the kidney function is working or not. And creatinine is part of that, creatinine. So that's another range that you need to be aware of. Okay, certainly to do with your ACE inhibitors. All right. One last piece that I want you to be aware of is a lot of patient teaching on page 350 and 351, all of what we've just talked about, but a lot more as well. You got to be aware with the alpha blockers, they can get a thing called first dose hypotension. This chick is having a really hard time getting in today. First dose hypotension. All right, so they can get that one dose and get blood pressure. She probably just needs to go over to somebody else's house and hang out and try and get in that way. Let's see. So anyway, that first dose syncope. All right. So obviously we want to teach that patient when they get out of bed, they get out of bed slowly, they put their feet down, take a minute before they stand up, don't get dizzy, you know, all of those types of things. We don't want them to fall. Making sure about driving as well, that they could get dizzy with driving. Some people can get sedated with some of these meds. Palpitations can happen.
The first
And
dose.
why do you think a lot of men might stop taking this med, by the way? Men.
Parts may not work.
What did I mention earlier that antihypertensives could do? Anyone? Yes, exactly. Erectile. So I'm recording, so I won't say too much, but that could have an effect as to why these patients, you know, are not compliant, right? That could be an issue. True?
The first dose phenomenon was for ACE inhibitors, right?
Actually, I mean, it could be with anyone, but the alpha adrenergic blockers, so the doxazosin, those types of things. And what it is some of them work centrally, some of them work peripherally. And so these more centrally acting ones can cause that first dose syncope. All right. Let's see, what else did I want to bring out in these big ones? Oh yeah, making sure your patients keep a blood pressure log, by the way. I always ask my patients if, you know, if they can buy one of those little machines to check their blood pressure periodically, or they can go to the store and get it done. The main thing is, though, try and get them to do it the same time and the same machine, so that you've got a good correlation there. Does that make sense? I do like seeing your faces. Thank you, guys. So much nicer to actually see you. I appreciate it. Thank you, Michaela, Mercedes. Anyone else want to join? I would love to see more people, quite honestly. It makes it a lot nicer for me, for sure, rather than just talking to myself. Because if it was me, I would just not be talking, quite honestly. All right. So let's see. So let's think about this as well. One more question before I move away from this. If the patient says, well, my blood pressure is great, can I stop taking them? What would you say?
No.
They gotta keep, yeah. They need to keep.
Is this the medication that if abruptly stopped, it'll create rebound hypertension? Is this?
Well, I mean, some of them could cause, absolutely, some of them could cause rebound hypertension. That's a good point. But the point is as well, the reason that their blood pressures come down is because of the meds, right? So we want them to carry on with those medications. But absolutely, rebound hypertension can occur with some of these medications for sure. So let's move on to angina meds. Let's go down here. Okay.
Dr. Fletcher, I have a quick question before you go.
Yeah.
I remember it was a question on the last test we had, and I think it was about, basically it was saying that if you stop taking this med abruptly, will it cause angina or would it cause rebound hypertension? I want to say it was metoprolol, I want to say. I
would think it would be rebound hypertension.
Okay, I just want to make sure because I seen something else about chest pain as well, and it wasn't a select all apply, it was a multiple choice answer.
We'll look it up in a little bit. Put it in the chat for me, Mercedes, so I remember to look that up for you. Or if somebody wants to look that up while we're doing this, that would be really helpful.
I'm
Everybody, metoprolol.
thank you.
Right? That would be great. All right, so can you see this little thing here? Anti-angina meds, right? So here's a patient with diabetes. She's got jaw pain, and it doesn't say the sort of standard pain, and I'm bringing this out for a reason. It's a woman with diabetes. Now, jaw pain can be part of it. The sort of like typical pain is that left-sided crushing chest pain or the left arm pain. It doesn't always happen like that. And actually with women, just to let you know, angina and chest pain often don't present in a sort of standardized picture. It might be, some people say, gosh, I feel like I've got GERD, I've got reflux, or they may say I've got back pain, something like that. So in this case, she's got jaw pain, all right? So she has been diagnosed with angina. So let's just look at this. Remember your key terms, by the way, at the beginning of each chapter. And the reason I'm bringing that out is on chapter 23, on page 353, right at the top there, angina. So it's that pain that is resulting of the fact that the heart, the supply of blood to the heart is insufficient to meet the demands of the heart. So you need to know what angina is with that chest pain. So here's the thing. They give her sublingual nitroglycerin. Now great. It's interesting. She breaks out in hives. Great. That's not what we wanted, right? And she's treated with Benadryl and Decadron, and she recovers. Great. That's awesome. Now, the thing is with nitroglycerin, we want nitroglycerin. I wouldn't say that this is always the case. Nitroglycerin gets used all the time, and nitroglycerin gets used in many different ways, okay? IV, PO, sublingual, patches, and we're going to talk about nitroglycerin a little bit in this chapter, in chapter 23. And unfortunately, I don't have time to go over a lot of the things I want to go over. But anyway, on page 354, it does talk about what is going on with ischemia. Obviously, if there's not enough perfusion to the heart, ischemia can happen, damage to the cells. And then as a result of that ischemia, we can get an infarct, all right? Which is basically death of that area, myocardial infarction. And it talks about it a little bit there in this page in 354, necrotic or dead tissue. So that's certainly not what we want. So we want to mitigate that situation, right? So we're going to use some things that are going to help with perfusion to that area. And there's a few things that we can use. There's three main classes. By the way, there's three classes of chest pain on page 354, and I just want to point them out to you. One is chronic stable angina, and mainly that's your patient that's got atherosclerosis or fat in the vessels. We're going to talk about that in a bit. But you know, they get angina, but they take nitroglycerin and it helps with it, and the pain goes away, and they're doing okay. So it's fairly stable, okay? They can take the meds, and within 15 minutes, the pain goes away. So it's stable, or they'll rest. Unstable angina is the next one down. This is the one, unfortunately, that usually ends in an MI, myocardial infarction. Okay, and then we have another one called vasospastic, or Prince-Metal one. Okay, and that's a sort of, we don't really know why it occurs. It just occurs at rest. And it does have a a regular pattern, but it's more of a spasm that occurs. And then we have several different types of drugs that we can use. We can use nitrates. We can use beta blockers. And where's my other one? And also calcium channel blockers. So these are the three. So again, you get my gist that I'm saying we're using these meds again and again and again. How cute. Is he helping you?
He had me open a banana for me. I mean,
Oh, okay, awesome. I thought he was helping you.
Mm-hmm.
So we have these nitrates. We have beta blockers. Remember, talked about beta blockers a little bit earlier, right? And then we've got these calcium channel blockers again. So these are the types of things that get used. So if you don't mind, let's just turn to page 356, because you're going to see some of these nitrates. You there? Page 356. So let's look at what these it's talking about calcium channel blockers. Well, first of all, on this little thing that we've got here, as you can see, look at what it says right here. The nurse, the patient has jaw pain and nausea. Women don't have the typical symptoms of an MI that men do, okay? So it's something that we really need to be aware of and clue into as part of our education and teaching. So I do want you to be aware of that. Also, you know, she took nitroglycerin, but for her, nitroglycerin, you know, made her break out. Did it take the symptoms away? Yes, but, you know, I mean, we've got to do something else as well. So remember, I just said we can use beta blockers and calcium channel blockers. So these are the three types of meds that we can use for angina, all right? And she actually has stable angina. Stable angina. All right. However, it says here, she was sweeping out her garage. She becomes sweaty. She gets that heaviness. She's having an MI, and she needs to obviously go to the hospital. Now, this is part and parcel of it, by the way. Can you see this right here? Always going to tell your patient they need to have an aspirin, baby aspirin, with chest pain as well. But there's certain things that we're going to do, beta blockers, calcium channel blockers, and morphine is usually used as well, if they can tolerate morphine. All right, now, that's just to give you a little idea of a picture of the type of patient. So let's just have a quick peek at these anti-angina meds. I want to just go into a little more detail. So certainly I want to go into detail about nitroglycerin. And there's a lot to do with nitroglycerin. It's really the most important drug that gets used. It's the prototypal drug with ischemic heart disease, such as angina. So I'm just going to bring this out. And it's on page 356. Nitroglycerin, as I say, can be used in different ways. It can be used IV. It can be used as a patch. It can be used sublingual. And the reason we like to use it that way is because it avoids that first pass effect. Remember the liver? Remember that whole liver thing? Well, that's not really going to help us get that med into that patient quickly and efficiently, is it? So this is why we use these other forms. So if you're going to use a sublingual nitroglycerin, it's going to have a very, very quick effect, which is what we want when somebody's having angina, correct? You want that quick effect. So that's something we want to be aware of. It talks about the fact that it's inside the cheek. It's very vascular. It gets into the bloodstream really quickly. There's also other ways, the spray, like a metered dose spray that can be used as well.
So if a patient was in cardiac arrest, would nitroglycerin be?
Well, if they're in cardiac arrest, then you're going to use dysrhythmia meds for that. I mean, this is the precursor to it.
Okay.
That's a whole different. This is the angina. This is the chest pain. This is, let's mitigate that happening. But that's a good point. So how we're going to mitigate it is a few different ways. And I know I'm jumping around a little bit, but I need to go to patient teaching about nitroglycerin. And the reason I want to do that is because this has come up on exams before, and it will come up on the exam. So let me just stop sharing for a minute and turn my camera back on. Hello, hello. All right, I'm back. So let's go to page 363. And again, I want to talk about nitroglycerin. So there's a couple of things I want you to be aware. Nitroglycerin, usually they put it in like a glass container. And the reason being, if you ever see it hanging, it will be in like a glass container, like a glass bottle IV. And, or it'll be in a non-PVC type of plastic. What happens with this particular med, it can leach into the plastic. The reason that's a big deal is, well, one, you don't want anything leaching into plastic, but the other reason is they're not going to get the full effect, the full dose of what we're trying to give if the nitroglycerin is leaching into plastic. You see where I'm going with that? So it'll be a non-PVC plastic bag or a glass bottle that you're going to see, one or the other. And look here again, what on earth with these meds, right? Cyanide. What's the deal? You're going to see this med is actually a concern as well. So we have to be careful about not exposing this one to the light as well, as potentially this one can turn into cyanide too. So we do have to be careful about these IV nitroglycerin. And again, really, you're going to see this if you're in the ICU. But you may end up in the ICU, right? That might be the area that you want to end up working in. So you do need to know about that.
So this would be wrapped in foil as well? Or is it okay?
Normally it's covered in a brown bag.
Okay.
Because it doesn't, it's stable for about 96 hours. I don't necessarily see the tubing covered in foil, but definitely is covered in a brown bag usually. But it is something to be aware of as well. So let's see what else I want to talk about. Oh yeah, exam question. Flashing lights, exam question. Nitroglycerin on page 363 at the top there. And also again on page 364 in patient-centered teaching. You need to understand how you're going to teach the patient about nitrates. All right. What do they got to do? They got to keep these, they're normally in a brown bottle. Makes sense, right? Just like the IV, you don't want to expose these to sunlight. You don't want to expose these to sunlight. So they're normally kept in like a tin or a brown little glass bottle. And the bottle. And exposure to light must be avoided. Let's see what else it says about them. So that's one of the big things. It also comes in an ointment. And this isn't on the exam. They come in like a patch or an ointment, and you may have to measure the amount of ointment. It might say like, you know, put 1/2 inch of the ointment. You actually put it on like a little piece of paper, and then you put it on the patient here. But remember, you got to take the other ones off, right? And also, of course, wear gloves. You don't really want to get nitroglycerin on you for sure. That would not be a good idea. So let's just go on page 364. There's a protocol here for giving sublingual nitroglycerin that I want you to be aware of. It's been on my exams, and I do need you to know this as patient teaching. So current guidelines. Patient has chest pain, they're going to take a sublingual nitroglycerin. If it's not relieved in 5 minutes, they're calling 911. And while they're doing that, they're taking another nitroglycerin, by the way. Okay. And they can take a third one 5 minutes later. So 3 total tablets that they can take within 15 minutes. So that little section there about patient teaching, about the sublingual, what they need to do, how they need to take it, how they need to store it. The other thing as well is the nitroglycerin tablets lose their potency. And we all know that most people do not throw their meds out when it says expired. Most people tend to keep their meds, right?
Yep.
They keep them, they're like, they'll be fine. Not with nitroglycerin. The potency is reduced. That is something you don't want if somebody is having angina or chest pain, right? So there's a lot of patient teaching. It says it's only potent for 3 to 6 months. So there is a lot of stuff with nitroglycerin. Now, the other thing as well, headaches. Nitrates can cause headaches, actually. So, so that's something as well. They can take an acetaminophen with that, but nitroglycerin can definitely cause a headache. So let's see if there's anything else on this little thing. Oh, we already talked about that. Now, I just do want to go back a little bit and just mention a couple of other meds. I mentioned to you beta blockers. Remember, or you may remember, or you may not. This is why I'm going over it. If somebody's having an MI or has had an MI, a myocardial infarction, remember we use beta blockers. Does anybody remember about the beta blocker and the catecholamines? And what I was saying is these catecholamines get released out of an MI, and they can actually cause more damage, right? More inflammation. So we use beta blockers when somebody has had an MI to help reduce that catecholamine effect. So if somebody's had an MI, they're going to be on a beta blocker, and they'll end in LOL, atenolol, metoprolol, one of these LOLs, all right? So, and it could be selective or it could be non-selective, right? So let's just look at a couple of them on page 358. Remember I said about the, there's a few things I want to mention about the beta blockers as well, a couple of things. Beta blockers slow the heart rate down, which, you know, we want to slow everything down. We want to actually prevent tachycardia. But the problem is it can mask that catecholamine effect or an increase in tachycardia with a couple of patients that are that might have a risk with this. Where I'm going with this, if somebody is a diabetic and they're becoming hypoglycemic, their body is naturally going to go, whoa, we need to do something about this. They're going to become tachycardic a little bit. That catecholamine, the adrenaline is going to fire up because of that hypoglycemia. Beta blockers can mask that effect. Okay, they can mask that effect, and the patient may not realize that they're becoming hypoglycemic. That's one issue. It can also cause hypoglycemia and hyperglycemia. So you can see it's a little bit tricky with your diabetic patient. So I just want you to be aware of that. So it can mask the signs and symptoms of hypoglycemia, and it can cause it. So just your patient needs to be aware of that. So if they are a diabetic, they certainly need to be checking their blood sugar. Okay. Let's see what else I wanted to say. All right, atenolol, it says it right here, is a cardioselective one, and you understand that now, I think. So it's metoprolol, and here we are, metoprolol. What is it that you were asking about on metoprolol?
It is a question that says if it is abruptly stopped, would it cause chest pain or would it cause
Angina?
Yeah, would it cause angina or would it cause rebound hypertension? And I want to say it's metoprolol.
I
And it
would
was
think rebound hypertension,
okay.
but as I say, I'm not seeing it here.
It
I
was
mean,
a, it was a test.
yeah, I would think rebound hypertension would be the issue, but we do use it as a medication for patients that have had angina or have had an MI. We use it, okay?
It's on page 363, right?
Does it say it? Where?
Midway.
63?
Midway on page 66.
Thank you.
363.
What does it say? Does it say black box warning? Let's see. Abrupt.
Beta blockers need to be given as ordered.
Yeah,
Black box
abrupt
warning.
withdrawal. Blah, blah, blah. Let me see what it, does it say why?
Abrupt
though?
withdrawal can precipitate rebound hypertension and worsening of tissue ischemia.
Got it.
Okay, so it can cause the worsening of ischemia, but it can cause rebound hypertension.
But it says that it's a calcium channel blocker.
No, it says beta blockers, and actually we're going to just mention about calcium. We are going to talk about calcium channel blockers as well, because that's another issue.
I'm just saying on 363 it says calcium channel blockers are to be taken as ordered without sudden withdrawal. Abrupt withdrawal can precipitate rebound hypertension.
Yes, you're correct. It does. And what we're just saying is that beta blockers do the same thing as well. So again, I appreciate this because that's part of the patient teaching, right? You don't want them to stop this stuff suddenly because they'll get rebound hypertension. And beta blockers specifically, like I've just been saying, these are the ones that are used to reduce catecholamines, epi, norepi, shoot, I've got the word, dopamine, right? So we want to mitigate that inflammatory process, and that's part of the reason why we give beta blockers. That's why you're going to see beta blockers being used post-MI. And as Victor was just saying as well, if you stop that, then the risk of the MI could worsen. So I don't know with that question that you saw whether it was actually saying rebound hypertension. I'd have to see how it was worded. So I'll have a look at that. Anybody else want to show me their faces, please? I'd like to see some other faces, not just mine. Anybody? Anybody?
We're here.
Well, all right. Let's just as well look at this calcium channel blocker, which, as I say, is the third one. Hello, thank you, Sierra. Nice to see you. It helps me as well to get to know you more. You know, I like seeing people in their homes. You know, when it's like 33 people in a room, this is actually nicer to see. Yeah, people live a little bit, right?
I like it like this. It's pretty cool.
You like it? Yeah. Not
I'm
bad.
in a state, but I don't have as much anxiety at home. I don't know. In class, I have anxiety when it comes to pharmacology.
Yeah, a bit more relaxed, right?
Yeah.
Well, I mean, but as I say, there's pros and cons, of course. You know, I'm sure those of you that have got little kids and stuff, it's probably a little difficult to concentrate and things like that to an extent. Yeah, you know, I'm sure. So I don't have it. I've got a cat sitting here. He's pretty chill.
Yeah.
So calcium channel blockers. Remember, as I say, this case that we just mentioned. So she had nitroglycerin. Yeah, it worked great, but she broke out in a rash and hives and all that sort of stuff. So then we looked at hello cutie. So then we looked at beta blockers and calcium channel blockers. So let's just have a look at calcium channel blockers as well on page 359. And as I say, a lot of them are going to end in pene, all right, like nifedipine, but some of them don't. I'm just warning you. Diltiazem is one that doesn't. Verapamil doesn't. And I don't know if you're going to see those on the HESI, but just bear in mind, as I say, that those are calcium channel blockers as well, okay? But for the most part, they're going to end in a peen, and that's going to be your ding, 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 that's a calcium channel blocker. How does it work? Well, they work on that. Calcium as an excitatory electrolyte. So what does it does? By blocking that action, we're preventing calcium from entering into that process. And so what it's actually going to do is it prevents muscle contraction. It helps with relaxation. All right. So it's going to help prevent contraction, and it's going to help muscle relaxation. And by the way, I've got a little video that I'm going to show you about cardiac conduction. I unfortunately don't have time to sort of go into all of the cellular processes, the pathophysiology, but it's a nice little video because it's only a couple of minutes long. But I like some of these videos as a visual to show you how the heart contracts and how it works. So I'm going to show you that when we get to it. But anyway, what have we got going on here? So we've got muscle relaxation, like I just said. It's relaxing those smooth muscles, so dilation. So what's it going to do? It's going to help with reducing blood pressure, right? That's what it's going to do. It also works as well. This is one of the meds that you're going to see is used as a dysrhythmia type of med. And that's why I'm mentioning this, because what happens is it works on the automaticity and the conduction of the sinoatrial node and the AV node. So it's very useful for cardiac dysrhythmias. So just bear in mind, like I've been saying, you're going to see this sprinkling of these meds through all of these 6 chapters. It's not just used for one thing. You'll see it used for a lot of different things. So calcium channel blockers. And then the other thing, like I've just mentioned, they're used as an anti-anginal effect. Why? Vasodilator, nice, it relaxes that smooth muscle. So it helps with that contractibility as well. So, all right, so a few things that it can be used for. One of the things with dysrhythmia that we're going to see, it can be used for what's called supraventricular tachycardia, PSVT. So angina, hypertension, and PSVT. The other thing, remember I mentioned there's 3 types of angina, and one of them was a spasm. Remember that? Yeah, this one gets used for that. Okay, again, because it's sort of, it's got that smooth muscle relaxation going on. Okay, can be used for lots of different things as well, by the way. Let's see, a couple of the meds. I'm trying not to get in the weeds too much with this, but there's so much to talk about when it comes to cardiac meds. I feel like I'm doing you a disservice by speeding through it, but
I see an important thing. So it says calcium channel blockers cannot be used with grapefruit once again.
Yes, that is a huge teaching point. And I pretty much, that's why I'm like, look, if you see grapefruit on an exam or a HESI, and you will, by the way, it's going to come up on another type of med. But seriously, grapefruit is just, just put a big X through it for everything, okay? Because of it sometimes it up-regulates the effect, sometimes it down-regulates the effect. So, but yeah, but and in this case, as it says, it reduces the metabolism. So we don't want that, do we? Okay, we certainly don't want that. So if you can see on page 360, diltiazem or cardizem, and maybe I sort of, cardizem, well, CA is the actual periodical sign for calcium, CA with 2 little plus signs on it, so CA. So that might help you remember, or just remember CA for calcium, and that might help you remember cardizem or, cardizem. I don't know if you can sort of think of it like calcium somehow, cardizem, diltiazem, okay? That might help you remember that it's a calcium channel blocker. Trying to help you connect some dots here a little bit with that. It's used in IV form as well. And then the other one that I just mentioned, amlodipine. I've mentioned that one a few times. Remember, they all end in a peen, Norvasc, and that gets used a lot for different things as well. Like I just said, it can be used for angina as well. Okay. All right. So let's look at what we're going to do with these meds. You're not going to give them if the pulse rate is less than 60, by the way. Okay.
For
Anti-angina meds.
angina meds.
Going to check that pulse rate. Apical pulse. Depending on what's going on with the patient, you definitely want to be careful because you don't want to drop their pulse too much. Okay. Let's see, what else do I want to bring out? The same things. Hypotension is a big risk as well. The beta blockers, like I just said, making sure you're looking at selective or non-selective. Some great points were just brought out as well, looking at that, not stopping these meds quickly because of rebound hypertension. Yeah. Let's see what else. And again, remember, we use them for lots of different things. Calcium channel blockers, beta blockers. We use them for angina, post-MI. We can use them for congestive heart failure. So we, again, want to be monitoring that weight, right? Edema, shortness of breath, that type of things. Let's see, grapefruit, of course. Nobody's friend. No one likes grapefruit. And what else? What else do I want to say for you? Again, with some of these meds, they can have that wax matrix that passes through the stool, right? It's not that that's not abnormal. That's, that is normal. So you got to let the patient know that they may see that, and that's a normal effect. The reason it's done in a wax matrix, by the way, is because some of these meds are what are called sustained release. So they're going slowly, right? You give them maybe one a day, and it's in this wax matrix so that it can be sustained release and not released all at once. And a couple of other things I want you to bear in mind, teaching points as well. Making sure, hot saunas, hot tubs, all of those types of things can have a vasodilating effect. Yeah, that makes sense, doesn't it? So they have to be careful if they're on these meds that are going to drop their blood pressure, that they don't get dizzy or hypotensive. So a lot of teaching regarding dizziness, falls, driving, those types of things. Okay. And I think those are the key points that I want to bring out. But the nitroglycerin stuff is the biggie, right? The key points: they lose their potency, how to give them, what to do, all of those things that I just went over, the patient teaching, things to highlight as well. They need to keep a fresh supply of those. They can't let them expire. They're going to lose their potency. All right. Why don't we do this? We're doing pretty well. It's 1:30. Why don't we have a 10-minute break? Does that make sense? Okay. And that way you can get something to eat if you want, whatever works for you. And then we'll go over a couple more chapters. We'll go from there. Do you like the little case study things along with it? Is that helpful to just get an idea? All right.
I have a quick question.
Yes, I like that.
Good.
And saunas and dizziness, was that for the angina meds?
I beg your pardon?
The hot tubs, they call. Yeah. Was that for the angina meds?
Yeah. I mean, it goes for all of them, quite honestly. If you're on an antihypertensive, being in the hot, anything that's going to cause a vasodilating effect, you can take a break if you want, guys. Okay. Anything that's going to take a vasodilating effect would be an issue. So that's part of the teaching for sure. All right, I am going to take a quick 5-minute break. I'm going to get my tea because you know how I am, and then I'll be back. Okay.
Hi,
see you.
Say hi.
Bye.
So it talks about the hot tub on page 363 at the bottom, if you guys were wondering.
Thank
You
you.
said 363?
Uh-huh.
Okay.
My puppy wants to say hi, y'all. She keeps trying to
He's
eat her
so
book.
cute.
You see her?
He's cute.
Oh, it's a girl. Oh.
I have another Yuki right here. She got a bad hair day. Y'all can't see her. You see her? Wait.
Oh.
So cute.
She tried to take her rubber band out her head, so now she look a mess. She doesn't like to wear a ponytail, but whatever. Hey, did you say hi to everyone? Since you over here eating my notebook? Say hi. She's so little. She's so spoiled. She's so spoiled. It ain't even funny.
Something to eat.
Not farm. It was.
Hello, guys. I just lost the access to EAQs in farm. Does anybody have the same issue?
Yes, it's now night station. I'm on the chat with Evolve, and they don't know how to help.
Same with me. I
Message
lost
would be
mine
well.
as well.
Mine's not working either.
Mine's is working.
All right, my lovely people. Woo.
Hey, Miss Patrick, can I ask you a question real quick?
Of course.
On the doses assessment, if like the answer is 35,000, if we don't put the comma, we're gonna get dinged for it if we just put like 35000.
No, you're not going to get dinged.
All right, thank you.
In fact, the comma isn't something you do anymore.
Okay.
Now I will, I think I mentioned this. The first couple of weeks, obviously, a lot of people didn't know, were brand new, but I would be more inclined to ding somebody if they didn't put a 0 before, say, 0.5, or if it was round to the whole number and they put 5.0. Do you see what I'm saying? Either a trailing 0 or a 0 was not put before an amount, because that could truly cause a dosage calc issue. Does that make sense?
Okay. Yes, ma'am. Thank you.
You're welcome. All right. Hang on. I got to take one more swig of my tea. Just is what it is, right? Sometimes. Nice to see you. Who was that? That was a person. Actually got to see a person. Can I see more people, please?
Kimberly.
Anybody? Thank you, ladies. Hi. Nice to see you. Who's that?
Patrick, we look a mess.
Who cares? You're at home, right? Is that why? Is that why people don't want to get on here? Because they're like, oh no. It's just nice. Isn't it nice to see people's faces, though?
It is.
Mm-hmm. Yeah, I think so. Even for a few minutes. It's nice to see where people live. And, sometimes I'll see kids pop in and stuff like that. And I'm like, that's adorable. I love it. Don't mind at all.
Mine won't stop bugging me.
Yeah, that is the problem. That is the problem with this type of, as I say, I don't mind this. Do I think it's for this, let me rephrase this. If you're at your sort of master's level, whatever, and this was just a lecture for an hour and a half, blah, 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 fine. But for people that are only just starting and developing their skills, I don't know that this is necessarily the best way long term. It's fine now and again, but
I gotta set this up.
You see what I'm saying?
Definitely not
I
ideal.
think it's not. I think it's harder to learn this way in some ways. Pros and cons, right? Nice one again. Thank you, Tropical Storm Elsa, whatever it is. Elsa. All right, so let's do a little bit to do with heart failure. Heart failure. Let me see. Is this the one I want to use yet? No. The dysrhythmia one is the one I want to use, the little video that I've got. And I actually like the little video thing. I'll show you the site because it's got all sorts of cool animated videos. And I was like, I like this site. I like it for me. All right. So chapter 24, we are moving on. And as I say, please feel free to chime in. Tomorrow, if I don't get through all of this, I'll be there tomorrow. And I want to go over the exam 2, which is basically respiratory, ear, eye, and eardrops, eye drops, and skin. But I will go over that with you tomorrow for sure. We'll be on campus and I'll give you some guidelines and guidance on that. So let's see, what am I doing? Screen share. Okay. Can you see that? The heart failure one? Anybody?
Yeah.
Thank you. I feel like I'm on stage. I need some feedback here. All right. So the heart failure, look at what I've put right there at the top. Inotropic, chronotropic, dromotropic. Do you remember those terms? Remember I said those key terms come up a lot?
Mm-hmm.
Remember that? The inotropic, chronotropic, and dromotropic. And one is, it's either positive or negative, depending on what's going on. So that's important in heart failure. And heart failure is more of a syndrome. It's as a result of a disease, usually that's gone on. And it's really the pump isn't able to pump sufficient amounts from the ventricles out to the body. And you're basically getting this backflow that occurs. So think of a hose pipe backing up and backing up and backing up, okay? Eventually it's going to start backing up into the body. It's going to affect obviously the lungs, and it's going to affect the periphery as well, which is why you get this edema and this shortness of breath that occurs, okay? So a lot of these drugs that we're using is to help with this inotropic, chronotropic, and dromotropic effect, to help with that push and the contractibility, so that the heart can actually pump more effectively. That's what we're trying to do. It talks about that a little bit on page 368, just so you know where I'm talking about. And I'm not going to necessarily get into ejection fraction. I don't know if you will talk about that in funds, but you're definitely going to start talking about that next term anyway. So it's just another term that is to do with how much blood is actually pushed, ejected out with the contraction. So I just want you to be aware of that term. But as I say, inotropic is to do with force, chronotropic is to do with rate. So I do want you to know those things. And dromotropic is that conduction. And bear that in mind, because that's going to become important when we talk in a minute about dysrhythmia, that dromotropic effect, okay? That's the actual conduction. All right, so a couple of meds that are really important in this chapter. Again, look at what we're going to look at. We're going to look at things that we've mentioned before. But this is the biggie. This is going to be on your test. The reason I've put it on here is because it's on the HESI, it's going to be on exams. It's another one of those biggies that you need to know about. Digoxin. So let's look at this person. He's got heart failure. And like I said, it's usually as a result of something. In this case, it's a result of abdominal surgery. And he's had digoxin. He's had this medication called digoxin. Okay, and he's doing well. He's a sports fanatic. He's an older person. Look, he's 78. But here's what's going on. He says, why are those guys hitting each other and falling on the ground? And this, although, you know, football, I talk about football as in soccer. You talk about football as a contact sport. I don't. Soccer isn't so much of a contact sport to me, but so I don't know if they mean football is in the sense of I mean football, or football in the sense of what you mean football. But anyway, even in football, they don't tend to actually hit themselves or hit each other. It's not, you know, it's not a mixed martial art type of sport, is it? So they're hitting each other, falling on the ground. The patient is confused. What do you think that might be as a result of? He's got this digoxin on board. Look at what digoxin does. It can cause toxicity. Now, this is the
probably an adverse effect.
Digoxin, it's a big deal. And actually, digoxin is measured, by the way, whenever we have things that cause a lot of toxicity. Remember I said you tend to do levels. Yeah, we've mentioned that before, haven't we? This is another one of these drugs that you would do drug levels on because of this toxicity. And here are some of the big issues with it. And this is what I really want you to be aware of. If a patient says, my vision is weird. I'm seeing halos. I'm seeing yellow halos, things like that, or purple halos, yellow halos. That's your big red flag as well, that there is digoxin toxicity on board, okay? So let's just, in our heart failure chapter, so we're in chapter 24, and on page 373, it starts talking about digoxin. Digoxin. It's a really old med. It's derived from the foxglove, actually, digitalis, by the way. Love foxgloves. They're really pretty looking flower, by the way. Anyway, digoxin, it used to be the mainstay of what we use, but because of this digoxin toxicity, it is used, but we can use a lot of other meds now instead of that, or alongside of it as well, because it has so many side effects. But what does it do? Well, it actually helps to slow and strengthen the heart, and it causes an increase in myocardial contractibility. So that positive inotrope effect, that positive contraction effect. And that's what we want it to do, right? We want it to help the heart pump that blood out effectively. So that's what it's going to do. So it becomes more efficient, and the output is more efficient as well. So it says it right down the bottom, a positive inotropic and also a negative chronotropic. So it slows that heart rate down. So what do you think one of the things that we are going to do as nurses before you give digoxin? Any idea?
Check the blood pressure.
Check the blood pressure. Vitals. Check the vitals.
Check the vitals. We would check the blood pressure. And what's the other thing that we always have to do? Check the
glucose
apical pulse. Whoever said that, thank you. Apical pulse. This is one of the ones that you have to make sure that pulse is 60 or above to give it, because it is going to reduce the heart rate. Okay, that's what it's going to do. So you're definitely going to be checking that apical pulse. All right. And so looking a little bit further into this, look at these adverse effects, unusual colored vision. And I will tell you, this is on an exam. I always put these types of things on exams. So just letting you know. So I would definitely know about digoxin. All right. That's a very unusual type of side effect that happens, isn't it? Other things as well. So we could get what's called heart block. And when you get to the point, probably next term, maybe later this term, I don't know, but you might look at some EKGs. And when we talk about heart block, what we're really talking about is the heart rate slows right down, way too low. And digoxin, unfortunately, can be one of the things that can cause that, okay? So we're going to monitor the digoxin levels. And if you look at this here, look at what we're talking about. So we know we've got these signs and symptoms. Look at what it says. What lab test does the nurse expect to be ordered? Well, digoxin levels, okay? And it says right here in my little cheat sheet, normal therapeutic levels are 0.5 to 2. So if it's higher than 2, we have a problem, Houston, don't we? Mm-hmm. So that's something to be aware of. The other thing as well is, look, hypocalcemia. I'm sorry, yeah, hypokalemia. I'm saying hypocalcemia. Hypokalemia. That can also cause an increased risk of digoxin toxicity. So we're going to measure the potassium levels as well, right? That's the other thing we need to check. So let's see what I want to talk about. What else do I want to talk about? Oh yeah, what are we going to do with this digoxin that's elevated? How are we going to treat it? Well, thankfully, look at what we can do. We can actually give an antibody that recognizes digoxin, and it sort of connects with that and it inactivates it. Okay, it's called DigiFab because it's fabulous. DigiFab. You'll remember that, won't you? You'll remember it with a British accent because it's fabulous. DigiFab. Okay. All right. It is the antidote for digoxin. Think you can remember that one? Digoxin Immune Fab, or DigiFab. So remember that. Now, the other big thing that, and the reason I'm saying, let's see, is that all I had on that one? Yes, we're going to go to dysrhythmia so I can stop sharing, put my video back on. There you go. Hi, I'm back. So on page 375, I want you to be aware of, it's a yellow box. And it says about that 0, and I've talked about it, but here it is in black and yellow, and it's really important. When you see these things in this book, by the way, with black and yellow, that's really the key point for med errors, preventing med errors, okay? That's when you don't want to do a trailing zero, and that is when you want to put a zero in front of it, okay? Because of the risk of a med error, especially as you can see with digoxin, right? A lot of adverse effects, a lot of toxicity, a lot of concerns with this med, as you can see. And if you see what the, on page 374, it says conditions predisposing to dig toxicity. Well, this guy that we talked about had a few of them. He was older, right? Recovering from surgery. Another big thing, by the way, that doesn't get, it talks about it here, hypothyroidism. Hypothyroidism is one of those disease processes that you really have to be careful with some of these medications, some of these heart medications. I see it a lot. You know, if you give too much of thyroid med, people can get palpitations. If you don't give enough, they can become they can go into what's called mixed edema coma. So there's a lot of concern with thyroid, with the thyroid, with these types of meds as well. So just as a sort of cheat sheet, looking at the types of things that could be risk factors for dig toxicity. Okay. All right. What else do I want to bring out in it? Oh, yes. This is what I want to bring out. All right. Herbs, because it's got an H in it. That's why I say herbs, not herbs. Ginseng, ginkgo, all of those types of herbs. Those can increase the drug levels. So that's something we want to be aware of, okay? We're going to monitor lots of different things, not just the dig level. We're going to monitor the liver enzymes, the renal, BUN, creatinine, renal function tests, all of those different things we're going to look at as well, along with looking, like you said, blood pressure, pulse, height, weight. What is their cognition? So that you know what the differences are, right? You know what the different cognition, is that their baseline? No, it's not. So there's a lot of different things that you would look at. Intake, output. I know you all know how to do that now, right? Intake and output. Started to learn that.
So because this medicine has so many different things it can cause and affect, is it one of those medicines that you have to sign a waiver for, or is it you just?
No, but the point is, and that's a great point, Zoria. Is that how I pronounce it, Zoria or Zoria?
Mercedes.
Oh, it's Mercedes. I'm sorry. I saw Zoria's little thing come up. So I thought it was. That's why this med, it's a great med. And, of course, I'm ancient. And, we used to give digoxin out. It was like, well, if you were on a med surge floor, you got digoxin. But I think that's why, with the toxicity of it and all of the side effects, and we can use other things now. So we don't tend to use digoxin as much as we used to use it. So, it's a great med. It's important, but it's sort of gone down in the scale of what we can use. We can use some of these other meds instead that function just as well. Okay. Let's see one of the things, as I say, on page 376, but no, you don't have to sign a waiver for it. Okay. I do want to point this out. And the reason I point these things out, as I say, because these are the things that have come up on exams and stuff, right? Page 376. As I say, we're looking at the electrolytes. You're going to look at hypokalemia, low potassium, because that can also precipitate digoxin toxicity, okay? Hypokalemia. And it says muscle weakness can occur. So if you've got somebody who's got muscle weakness and confusion, that's going to confound that dig toxicity anyway, but I just want you to be aware of those things, okay? But the big thing I think you might see is if somebody's getting those yellow halos, and I've got to say, I have never had that happen, but I presume it can happen. But these halos, yellow, green, even purple halos can occur. All right. But definitely there's a lot. I mean, predominantly in this chapter, it talks about digoxin. That's mainly what it talks about. Okay. Let's see. Trying to think if there's anything else I want to really bring out. At the end of that chapter, again, patient teaching, patient teaching, patient teaching, daily weights, electrolytes, monitoring their vital signs. Okay. It's a whole lot. All right. Now, I am going to share my screen. Hang on, let me do this. Screen share. Give me a second. Let me bring this over here. Okay. Okay, can you all see that?
Yeah.
Good.
Yes, it's up there.
Awesome. All right, this is only a couple of minutes, but we're going to just talk about anti-dysrhythmia drugs. And remember I mentioned conduction, okay? And I don't know whether you've had any in funds, whether you've talked about this at all. And of course, you may have done patho and things of that nature, but I just want to show you this so that you've got some idea of what I'm talking about, okay? It's only a couple of minutes, but I really like this company. I like their animation. And I thought it's on YouTube and it has tons of different animations. So you might find that a helpful tool for you as well. If, you know, a lot of you are visual. So this might be a company that you like their animation. All right.
Conduction system consists of the following
Can you hear that?
The sinoatrial node, or SA node, located in the right atrium near the entrance of the superior vena cava. This is the natural pacemaker of the heart. It initiates all heartbeat and determines heart rate. Electrical impulses from the SA node spread throughout both atria and stimulate them to contract. The atrioventricular node, or AV node, located on the other side of the right atrium near the AV valve. The AV node serves as electrical gateway to the ventricles. It delays the passage of electrical impulses to the ventricles. This delay is to ensure that the atria have ejected all the blood into the ventricles before the ventricles contract. The AV node receives signals from the SA node and passes them onto the atrioventricular bundle, AV bundle, or bundle of His. This bundle is then divided into right and left bundle branches, which conduct the impulses toward the apex of the heart. The signals are then passed onto Purkinje fibers, turning upward and spreading throughout the ventricular myocardium. Electrical activities of the heart can be recorded in the form of electrocardiogram, ECG, or EKG. An ECG is a composite recording of all the action potentials produced by the nodes and the cells of the myocardium. Each wave or segment of the ECG corresponds to a certain event of the cardiac electrical cycle. When the atria are full of blood, the SA node fires, electrical signals spread throughout the atria and cause them to depolarize. This is represented by the P wave on the ECG. Atrial contraction, or atrial systole, starts about 100 milliseconds after the P wave begins. The PQ segment represents the time the signals travel from the SA node to the AV node. The QRS complex marks the firing of the AV node and represents ventricular depolarization. Q wave corresponds to depolarization of the interventricular septum. R wave is produced by depolarization of the main mass of the ventricles. S wave represents the last phase of ventricular depolarization at the base of the heart. Atrial repolarization also occurs during this time, but the signal is obscured by the large QRS complex. The ST segment reflects the plateau in the myocardial action potential. This is when the ventricles contract and pump blood. The T wave represents ventricular repolarization immediately before ventricular relaxation, or ventricular diastole. The cycle repeats itself with every heartbeat.
Okay. All right. So, let's see. So I felt like that tiny little video probably can put into, pictures much better than I could talk about it, quite frankly. So that's why I just wanted to show you. And sorry, guys. I don't know why it's, all right. I don't need you or you. So let me get rid of you all. All right. Excellent. That's that. So let's look and see what we've got. Dysrhythmia. So did that help you a little bit to understand? And in your book, on page 385, it just shows you an EKG or ECG. And what you're seeing on an EKG is basically that electrical stimulation. I didn't know whether you're aware of that or not. And now you can sort of get a visual of what you're looking at when you see an EKG strip, a little bit, all right? That's just the basics of it to give you an idea. So when we talk about dysrhythmia, if you look at this, this actual EKG right here, this is a normal. This is what it's supposed to look like. But when we have a dysrhythmia, it basically looks like on page 386 and 387. Or can look like that, and some of the rhythms that it could look like instead, okay? We don't really want our heart rhythms to look like that, right? That's not normal. And obviously, many of them are life-threatening as well. So again, some of the meds that we're going to use, and you may see some of the meds that we've used before in this section as well. So let's just do this. I am going to share my screen again. Okay, share. All right. So hopefully in a minute, you will see this one on dysrhythmia, okay? So we have a 50-year-old male coming in, heart racing, he has issues, as I say, that he's got some dysrhythmia going on, feels short of breath, all of the rest of it. So they do an IV, they put him on a heart monitor. And remember I mentioned earlier, and that's why I mentioned it, this particular thing, paroxysmal supraventricular tachycardia, okay? So his heart is beating very rapidly, and basically it's causing the ventricles to beat very rapidly, okay? So this dysrhythmia is going on. And I don't know, yeah, there is a picture of it, actually on page 386. It's about the third EKG strip down in your book, just shows a pretty picture of that. Okay, now, I can promise you on the farm, there isn't going to be questions on the Vaughan-Williams classification of antidysrhythmic drugs. I'm not going to test you on things like that. And I have not seen that sort of stuff on the HESI. It's very, very specific. So I'm not going to get too into that right now. And as I say, as you progress through term 4, 5, and 6, you're going to become more and more familiar with it. What I really want to do is just help you understand a little bit about some of these dysrhythmic drugs and some of the things that we can use. And again, look at this. What can we use? Well, we've seen this before, haven't we? Calcium channel blockers. Ending in a peen, right? Like Norvasc. wouldn't necessarily be Norvasc. But the reason I'm bringing this out to you is this one right here, Verapamil. Verapamil has been on a HESI. It has been. So I need you to understand that this is a calcium channel blocker. All right. It doesn't have the peen on the end, but it might have it in parenthesis, Kalan. And if you chop that off, what have you got? Ca. That might help you remember calcium. You see where I'm going with that? It's detective work. That's what it is.
Did everybody just get that connection issue, or was it just me?
It was just you. I seen your screen.
No, it wasn't just you. It's me too.
Ah. Well, remember this is recorded, okay? So we can always, you can always listen. You can always go to this section and go to the actual recording of it. So that's a good thing.
Okay.
But can you still see the screen? Can you still, you can see all this? Okay, all right. So calcium channel blockers are one of the ones that we can use. And that is what it's actually on this Vaughan Williams class. It's actually a class 4. And what does it do? Well, we talked earlier about the nice thing about these calcium channel blockers. They reduce excitability, don't they? They're used for lots of different things. And so in this case, they can be used to reduce that excitability and hopefully treat that cardiac dysrhythmia. So that's one of the things that they can be used for. And if you look on page 388, there's a green box and also a purple box as well. And Verapamil comes up a couple of times about that. Some of the others do as well, diltiazem or cardizem. So remember, a lot of these meds that may not have a peen on the end, their trade names often have a CA in there that would help you think, maybe that's something to do with calcium, and that might help connect the dots a little bit, all right? Okay, so let's just look at some of the issues, though, with these meds. Well, it's great that they're doing that, but some of these dysrhythmia meds, unfortunately, can then throw the patient into another dysrhythmia. So that's something to just be aware of, okay? And antidysrhythmic drugs can actually worsen existing dysrhythmias, and so it can actually create another dysrhythmia. So we do have a lot of different meds that can be used, but I just wanted you really, I was just focusing a little bit on these calcium channel blockers right now because of some of the things that I've seen in the HESIs before, and I wanted you to be aware of these particular drugs. So anyway, they resolved the PSVT. They managed to resolve it. And what did they do? Well, because that worked, well, they decided that made sense to put the patient on this long term. So they would put the patient on an oral form of that, an oral form of these calcium channel blockers like Norvasc. Here's another one, Precardia, and here's a few of them as well. So some of them you would start out obviously IV, and then you would convert them to an oral one, okay? Amlodipine, again, bear in mind this peen. Now here's a big issue. This is one of the side effects that I want you to be aware of with this. Edema, peripheral edema. Well, that's a problem, isn't it? You know, the patient might see this peripheral edema occurring, and what if they've got congestive heart failure as well? So that could be an issue, couldn't it? All right. So seeing this peripheral edema could be very, very concerning, and they could be thinking that their heart is failing. It may be just this peripheral edema, and we have to give some other things to get that fluid off them. Another thing as well, vasodilation and headaches, hypotension is another thing that can occur. Just trying to see if there's anything major that I don't really think you're going to get much to do with dysrhythmias. But as I say, I just wanted to really bring that point out. And as you go through, there is one I want to talk about, maybe two. If you could please turn to page 392. Okay. Okay. And just FYI, we'll talk about the EAQs in a minute. Somebody sent me a message about the EAQs. It may be a case that I have to go in and redo all your EAQs because we updated the book for you. And as a result of updating that book, it may have cancelled out all of the EAQs. So don't stress too much. I'll have to figure that out. And it may be a case of me having to go in and do all 32 50 whatever EAQs that you have to do. Fun, eh? Looks like somebody's screen is frozen. Michaela's screen is frozen up. All right, so let's just look at lidocaine. Remember lidocaine? Remember when we were talking about anesthetics, things of that nature? Remember that drug came up? Yeah? Somebody's, yes, they remember it, right? But we actually can use lidocaine as well for dysrhythmias, okay? And of course, you're going to give it IV because you don't want it going through that first pass effect. You don't want it going through the liver. You need to use that thing immediately. It needs to have an immediate effect, doesn't it? So anyway, lidocaine, I want you to be aware of that. And one of the big reasons I want you to be aware of it is because remember, if we're using lidocaine for other things, it can be used, as I say, for an anesthetic. Have an awareness that it can also, while it can have an effect on dysrhythmias, it can also cause dysrhythmias, right? So I just want you to be aware of that. A lot of side effects with lidocaine. Of course, it's a different dosing that would be used, but even so, I just want to put that into your awareness with this particular med. Let's see, of course, cardiovascular effects can be, the adverse effects could be hypotension, bradycardia, and other dysrhythmias. So just be aware of that. I'm trying to see if there was anything else. Again, beta blockers can get used. Like I said, that sprinkling of these meds are going to be used throughout all of these chapters. Okay. And let's see. I'm trying to think if there's anything else major I want you to know about. Again, beta blockers, the big thing with the beta blockers that are used for an MI is that cardioprotective effect, all right? Cardioprotective. It reduces the catecholamines. And again, and it talks about that on 393. So if you haven't got that in your brain, I would suggest you just highlight that section again. It has been on exams, so I would make sure that you are aware of that, okay? And one of the big things about a beta blocker, patients post-MI, there's a lot of studies that have shown if you put them on a beta blocker, it does significantly reduce the sudden cardiac death, okay? So good to know. And metoprolol, again, it talks about it on page 394. The only thing I want to mention to you about, let's see, again, down the bottom of page 395, diltiazem, cardizem, it's got a CA. What do you think that might be? Calcium channel blocker, right? And then verapamil on page 396. Verapamil is the one that I just talked about in this particular case study. Verapamil, it's a calcium channel blocker on 396. It's used to treat and convert PSVT. So, trying to think if there's anything else. Oh yeah, there is another one. On page 396, there's a medication called adenosine. Adenosine. Now, you're going to get to hear about adenosine, as I say, as you go through your adult health 1 and 2 and on and on and on when we talk about dysrhythmias. But adenosine, it actually is used to convert to sinus rhythm. One of the things that you're going to notice with adenosine, if you look at a monitor, cardiac monitor, is when they push this thing, and they'll push it really fast, is actually the patient will flatline for a second or two, and then it will jump into a rhythm. And that is something that you'll see with this particular med. It has a very, very, very short half-life. If you look at it, onset is immediate, half-life is 10 seconds, okay? So it basically just resets. It's used for cardiac conversion. But I do want you to be aware of that medication. If you've ever seen it, it's sort of like, wow, sort of interesting. But I do want you to be aware of that med. Let's see. Lidocaine. Again, making sure you understand about lidocaine. And also, if you see lidocaine with epinephrine, by the way, remember what we use epinephrine for sometimes? It's a vasoconstrictor, right? So it stops. For instance, if you're using it in a surgery procedure, it's actually helpful to constrict the blood flow. Okay, so that's something to be aware of. Down the bottom of page 397. Now, a couple of things I want you to be aware of, and I mentioned this before about the differences with men and women, how they present with a potential MI or angina. Remember, women can present very differently to men. It might not be the standard type of look that they're going to present with. They're going to present differently. And also with AFib, afibrillation, and that is another dysrhythmia. And there is a picture of that on these EKG strips that you may see as well. Afibrillation is the second one down. So you may just want to have a look at that. And again, women present differently from men. So I do think that these are important things to bear in mind when we're looking at our patient teaching, because you want to teach your patient that, right? If they've had an episode of AFib, or if they've had some angina, and you're talking to a woman versus a man, that's part of the patient teaching for them to understand what that looks like or what that feels like for them, so that they know to report it. Yeah, those are the types of things I want you to be aware of. So again, our patient teaching, very important. Down the bottom of 399 and also on page 400. All right. Okay. Do you need a quick break, or are you okay? Or you want me to carry on and talk about something else for a minute? Talk about something else for a minute? Or are you okay? Are you guys doing all right?
Yeah.
All right.
Yes.
Because we are, I tell you one thing, we're actually getting through these chapters. I'm sort of surprised. You keeping up okay?
Yeah.
Accent, yeah.
Share this video with us that you're recording.
Yes, absolutely.
Well,
Yes.
Thank you so much.
Yeah, of course. That's the whole point, right? So that you've got this information. Especially as well, you know, sometimes like I can see some people's screens freezing up and stuff like that, and that can occur. So it's helpful to have these pieces. But yeah, absolutely. All right. Let's see what I want to talk about next. So we're going to look at chapter 26. Okay. Okay, you can all see this, I think.
Yes.
Okay, so I want you to understand there is a difference between an anticoagulant and a thrombolytic. And first of all, before we go into anything, I'm gonna, and it says it right here, the thrombolytics, they're a certain type of medication, and they're what are called clot busters. They literally will break open the clot, and those are used in specific circumstances, all right? But the anticoagulants prevent a clot from forming. Okay, so that's a lot of what we're going to talk about. And on page 404, I just want to show you a couple of, I'm not going to go into the cascades, but I do want to show you that there are differences here. And there's the top one and the bottom one. So one of them is looking at how basically factors inactivated by heparin and then factors inactivated by warfarin. And it just shows the different pathways of how these anticoagulants work. They block certain areas of these pathways, and that's how they work. So it's slightly different from what is called the thrombolytics, and I just want you to be aware of that, that's all. So as we look at things, so first of all, what do you think a clot might look like? Any idea? There's some examples here. What happens if we have a clot in our body, or if the blood gets too thick? What could be the problems?
Stop circulation and other blood from flowing.
Yeah, absolutely. And that could be a problem because it could cause, say, a stroke, couldn't it? Right? A PE or DVT, deep vein thrombosis could be caused. So lots of issues that could become big issues if we actually don't thin the blood out for whatever reason. Okay, and you think about it, when people are sitting for a long time. Actually, I'm standing. I couldn't bear the thought of sitting for 3.5 hours, so I'm actually standing at this desk. But when people are on long flights, right, long haul flights, we have to get them to move. Yeah. What about our patients that are having surgery or post-surgery? We want to make sure they don't develop a clot, don't we? So there's things that we can do. We can use low molecular weight heparin. Excuse me, just drink some water. Sequential hose, the pressure hose, right, that can be used. But more importantly, we want to get them up and get them moving as well, as much as we can. So let's look at this case study about this coagulation. This is a pretty big one. And at the top here, I just want you to be aware of some of the terms: heparin, warfarin, ginkgo. These are the types of things that potentially are going to crop up on a HESI. Okay, so you do need to be aware of them big time. Okay, so let's look at this. This is a young person, came in with leg pain and swelling. He has a clot, a DVT, and looks like they started him on some heparin IV, right? They normally give a bolus and then they'll do that continuous infusion. Remember, we've seen a couple of dosage calc things like that. I don't know if we have gone into that yet, but we will. Probably tomorrow I'll do a couple of dosage calcs to do with that, okay? So one of the things you need to be aware of is this little piece right here. When somebody has a heparin drip, we're going to monitor using this, the activated partial thromboplastin time, APTT. And depending on what that APTT shows, depends on whether we titrate the rate up or down on the heparin drip. Okay, there's normally protocols related to this. So I want you to be aware of that. Now, is the patient going to go home on a heparin drip?
No.
What do you think?
No.
No. So what happens normally is we bridge that patient from heparin to what's called warfarin or Coumadin, which actually is rat poison, by the way. And what this does, it inhibits vitamin K. And I'm telling you that for a reason. It inhibits vitamin K because guess what the antidote is? If somebody has too much warfarin on board, what do you think it might be? I just said it.
Vitamin K.
Vitamin K. Exactly. Vitamin K. I can't say vitamin. I'm going to say vitamin. Sorry. I have to. Can't I? Americanize me. All right. So the patient would go home on warfarin, right? And there's a lot of teaching involved in this scenario right here. So let's just look at some pieces. First of all, heparin. Heparin is derived from animal sources. And as I said, you're monitoring the heparin through the bleeding time, which is the APTT. Now, we also have these other forms of synthetic heparin that are given subcutaneously. And usually you're going to give them into sort of the fatty areas, like around the tummy, not around the umbilicus, or you might be able to give it into the upper thigh, those types of areas. And actually, you don't need to monitor, you don't need to do these levels when you're giving this subcutaneous Lovenox, as it's often called, okay? Lovenox, low molecular weight heparin is one example of that. But a couple of things that you need to know about heparin. First of all, on page 407, adverse effects. So let's look at what an adverse effect of heparin could be. What are we trying to do? It's an anticoagulant. It's stopping the patient from clotting. So what do you think the problem could be? How about bleeding?
Maybe it's
anemia.
It's thinning the blood, right? It's thinning the blood. So the patient could bleed, couldn't they? Too much bleeding. Yeah, they could end up having systemic bleeding. That's one of the concerns, right? There's another big concern as well, by the way, and it talks about it right here. It's called HIT, heparin-induced thrombocytopenia. So what actually happens with this, the clotting cascade that I'm talking about, what actually occurs in this clotting cascade is it's affecting various aspects of, say, preventing things from clotting, but it's not supposed to affect platelets. It's not really affecting that. But the problem is what happens with this, it does affect the platelets. Platelets are slightly different. Platelets create like a sort of Band-Aid clot initially, and then this is a different clotting cascade. So the problem is these patients' platelets start dropping as well. And that can be an acute situation where the patient can then potentially bleed out. Okay. So, this is not what we want to occur. So if somebody is HIT positive and there's a blood test that they can do to determine that, then they're going to stop heparin and they're going to use a different form called agatroban. So I just want you to be aware that there is a high risk of bleeding with heparin. Okay, so bear that in mind. All right, and of course we can use this heparin for all sorts of things, right? Unstable angina, we can use it for AFib, we can use it for if we've got mechanical devices going, anything that needs a little bit more blood flow and making sure that the patient isn't going to be too clotty is what we're going to use it for. Again, we're going to do levels, like I said, and unfortunately, just like a lot of the things that we do levels on, why do we do them? Well, because they can become toxic. Well, we're going to stop heparin straight away if they're toxic, yeah? And we can reverse it with a drug called protamine sulfate. And that's on page 407. Protamine sulfate. Warfarin is another drug that we actually utilize, okay? We're going to talk about that one next. So let's look at this one, warfarin.
So what did you say about protamine?
Protamine sulfate is the antidote for heparin. It reverses the effect of heparin.
What's the antidote?
Heparin. Let me put it in.
Protamine?
Yes, protamine.
Yeah.
Hey.
Protamine. It's on page 407. Let me put it here. Heparin. Antidote is protamine. Oops, sorry, spelling it wrong. Protamine. Protamine. Protamine sulfate. There you go.
It's the 12th sentence in that paragraph on 407 under management of overdose.
Yeah. And we're going to talk about it. It comes up a few times, believe me, because this is a biggie. This is a biggie for sure. In fact, on page 410, it talks about heparin. It talks about HIT, okay, which is a concern. And let's see. And of course, you want to be aware that heparin is It's kilogram. You're gonna use your kilogram. It's weight based. Okay, so you're not going to use pounds. It's kilogram. So on page 410, it talks about heparin. So let me just go back a little bit. And I want to go to, where do I want to go to? I want to talk about warfarin. So let's look at this case study.
Both hits or just one?
Beg your pardon?
Do we need to know both?
Yes.
Okay.
You'll need to know about warfarin and heparin. Okay? Warfarin and heparin, which is why I'm showing you this little case study right here. So this is a 70-year-old patient with AFib. And a lot of people, by the way, have chronic AFib. But the problem is, think about this. So the heart, if you sort of saw a visualization of what's going on, I showed you a brief visualization of the patient, of that heart, and it's beating, it's contracting and relaxing and contracting and relaxing, right, appropriately. But if the rhythm is not normal, a fibrillation is literally that. It sort of is quivering. It's not working properly. So that sets the heart up to throw off a clot. So patients are going to be on a blood thinner. Now, they don't necessarily need to be on heparin because they're going to be at home, but they could be on something like warfarin. Warfarin is one of them. But, you know, nowadays, most people honestly end up on one of the newer anticoagulant meds, and there's a reason for that too. But warfarin comes up on the exams and HESIS, so this is why I'm talking about warfarin. All right. So let's see. This guy has AFib. He's going to be on warfarin. Now, warfarin is monitored in another way. We monitor what's called the PT and INR. And warfarin is on page 411, by the way. Now, and believe me, this piece comes up on exams. So you're going to want to know this too. Now, a normal INR, meaning I'm not on heparin, I'm not on Coumadin. So I'm not on any of these meds. So my INR is probably 1. Okay, this is, whereas a therapeutic INR, somebody who's on these medicines to make their blood thinner, we want it between 2 and 3.5. That's where we want it. We want it a bit thinner so that they don't throw a clot. That's what we're looking for. That's what we call therapeutic. But again, if we're measuring levels, just like any of the other meds that we've monitored their levels, that is a big red flag to you to say, that means it could become toxic or not therapeutic, right? That's why we're monitoring. And so if it becomes too much, If it becomes too thin, then we're going to give vitamin K.
Okay, so a PT-INR levels need to be between 2 point, what did you say, 2.2?
No,
2 to 3.5.
2 to 3.5 in this book. Now, I'm going by this book. You know, when you're working in the hospitals, they may have a slightly different protocol to this, but I'm just going from this. Okay, generally speaking, around about 2.
And if on Coumadin, their PT-INR level would be lower because
if they're not, no, what I'm saying is somebody like myself, I'm not on a blood thinner. So the normal INR without a blood thinner is about 1. Because that's what we're measuring. We're measuring how long does it take to clot. That's basically what we're measuring with this particular level, with this INR, international, I can't remember what the international normalized ratio. But the PT and INR, we're measuring how long does it take the blood to clot, basically.
Okay.
All right. So I just want you to be aware of that.
And you said something in regards to vitamin K. Did you say that's the antidote?
Yes, it is.
To Coumadin.
Correct. Or warfarin, same thing, Coumadin or warfarin.
So is there a therapeutic level for heparin?
You know, that's a very good point. That tends to be a protocol and it depends what they're trying to do. But, you know, I don't have it in here as to what that level would be. So I wouldn't worry about that too much. Just bear in mind this. I think it's dose dependent. Now, one of the things down the bottom here, page 411, warfarin inhibits vitamin K clotting factors, okay? So one of the teaching points here, there's some teaching points. Let's see, is this still up?
So if you're taking that and you're eating food rich in vitamin K, it's gonna have an effect on it, right?
Correct. Good job. Yeah. And I was hoping that this little case study talks about that. It talks about the INR, all right? But it doesn't talk about the foods. Now, one of the things I need you to be aware is there's a misconception talks about, it doesn't mean the patient can't ever have kale, because I know that everybody loves kale, right? I'm being sarcastic. I like kale, but I don't imagine that everybody loves kale. Unless you all do.
Kale and spinach mixed together.
Well, I actually do like kale, but my point is, you know, they can eat leafy green vegetables. That's okay. They can eat stuff like that. But it's the excess, all right? You don't want them just eating leafy green vegetables because that's going to have a counter effect on the warfarin. It's got vitamin K in it. So you've got to look at a lot of these green vegetables. We don't want them having stuff like that. Now, there's a couple of other things as well. Remember I said how certain supplements tend to crop up on exams and HESs? Yep. Guess what? Things like St. John's wort can interact with it. Ginkgo, garlic, right? A lot of people eat garlic as an anticoagulant, don't they? So all of those types of things you need to bear in mind that you're going to teach your patient for sure. Let's see if there's anything that I want to bring out in there. Nope, I'm going to go on to lipids in a minute, but there's a few things in this chapter that I really, really want you to be aware of. So I am just going to mention a couple of other things. Oh yeah. So I mentioned to you that there are some other drugs, like Plavix, for instance, is one of them. I'm trying to just scroll through and find what I want to find. Xarelto, where are you? Oh yeah. So here's one just an example for you. It's the new oral anticoagulant medications, otherwise known as NOAC for short. And these are the types of drugs, like it says one here, dabigatran. So there's a lot of these types of meds now that are coming out that are being used more often than, honestly, than warfarin is, because you don't need to monitor them. You know, they can do like a once-a-day dosing. They don't need to do PT and INRs, which is a lot better for the patient. So that makes more sense, doesn't it? And they don't have the sort of toxicity that Coumadin does, that warfarin does. They don't necessarily need the antidote. So they can be used as an anticoagulant. So just bear in mind that really we're sort of moving, most of the time you're going to, on the whole in the hospitals and in work, you're not so much going to see warfarin and warfarin clinics. You're going to see more of these newer anticoagulants being used. So I do want you to be aware of that. And the other thing I want you to be aware of is, as I say, it's called Lovenox, or low molecular weight heparin, or enoxaparin. These are your sub-Q versions that can be used sometimes instead of heparin, you know. So they'll use those pre-surgery, pre-op, post-op, those types of things. They might use these types of medications. If somebody is in the hospital and they're bed-bound, they may use these. You may see these used a lot. So I do want you to be aware of those. What else? What else? Oh yeah, converting heparin to warfarin. Normally it's a bridge. So you're going to bridge that. So they'll have the heparin drip going and they'll incorporate warfarin into it as well. And they'll bridge that patient over about 3 to 5 days. That's something to bear in mind. I've seen that sort of stuff on a test. Now, let me just mention to you about the clot busters. So these are different. These are the ones that basically, the other ones are the anticoagulants. These are the ones that actually clot, you know, break open that, lyse the clot. All right. So I want you to be aware of those. And that is on page 415. It used to be something that our bodies actually produced. It was isolated from patients' blood in streptokinase. Okay, we don't use that anymore. They use a synthetic one. TPA is what is used, clotbuster. It's a recombinant DNA. So be aware of that. And I don't necessarily think you're going to get a question on that, but I just wanted you to be aware of TPA. One of the big things to be aware is it gets used, say, for ischemic stroke. You would not use this for a hemorrhagic stroke. You'll make the patient bleed out. Okay, so that's you would make that hemorrhagic stroke a lot. You know, they would cause bleeding from that. I'm trying to think if there's anything really that I wanted to bring out in that. Not really. Oh, the other thing, pardon? Yes.
You said heparin is the bridge to warfarin reference?
No, the other way around. So you've got a heparin drip going. Okay, they've got the heparin drip going. They're monitoring them. They're getting to the the point where they're like, yeah, we can bridge this patient over now to an oral form of an anticoagulant. So then they'll bridge them with warfarin. And then they'll start monitoring that PT and INR, seeing where they are from an anticoagulant standpoint. And then they'll take them off the heparin, and then they can go home on the warfarin. Does that make sense?
So heparin is in the hospital and then warfarin is at home.
Mm-hmm.
Yes, predominant, if you want to think of it that way, for sure.
So basically, heparin and warfarin do the same things, but because heparin
IV,
so you give you give heparin in the hospital to kind of bridge them over. You kind of put them on warfarin and do the same thing, but at home because you can't take heparin home.
Mm-hmm.
Yes.
Okay, got
Yeah.
it.
There you go. And just a couple of things. Remember I mentioned the patient who had had chest pain and an MI, and one of the first things you do is a baby aspirin. Remember I mentioned that? Yeah. So aspirin, by the way, and this is on page 413. Actually, it starts all the way back on 411. We've got another form of antiplatelet drugs. So remember I said that there's a clotting cascade, and what we're doing is this blocking of this anticoagulant type of cascade. That's one form. That's your warfarin, that's your heparin, okay? These drugs work slightly different. What these do is they work on that platelet formation. So they prevent, well, I don't really want to say that they don't prevent platelets, because you still have platelets, but it is known as an antiplatelet drug. So they prevent the clot from forming. They help to prevent that. Now, do they still have platelets? Yes, of course, but they do prevent this platelet adhesion that could occur. So it starts at the beginning of the clotting cascade. So it works slightly differently. So that's why you might see a patient on aspirin, a baby aspirin, and you may see them on another type of clotting drug as well. Now, sometimes you'll see them on things like on page 412, there's a few of them. You've got aspirin, and then clopidogrel or Plavix. So you may see two of them used together.
So that wouldn't create an interaction with two.
No, they work well together.
So two antiplatelet drugs can be used together?
Yes. And sometimes, like patients who are post-MI, you're going to need to use stuff like that, because you don't want to throw in a clot, all right? You've already had an MI, so they're high risk. Somebody with AFib, these types of patients, potentially, you're going to watch them really carefully to prevent any clotting occurring. But again, what are the risks of that, right? What's the risk?
Bleeding.
What's the big risk?
Bleeding?
Yeah, bleeding. And that happens, doesn't it? I mean, they bleed more easily, unfortunately. They bang themselves or cut themselves and, bleed so much more easily. So these are the things that we have to watch. There's that balancing act still. Now, what type of patient, by the way, do we not give aspirin to?
Liver, aspirin, people on blood thinners? I mean,
what about Ray's syndrome? Remember Ray's syndrome?
Oh,
For children, Ray's syndrome. And of course, obviously, if you've got an allergy to aspirin, but that's something we do want to bear in mind, okay? But it has a slightly different type of cascading effect. It actually helps to prevent and I'm just reading it to see if I can help you a little bit more. It prevents platelets from actually creating a clot in the first place. That's what it does. It's not that you don't have the platelets, but it helps with that, preventing that platelet clot from forming. I think that's how to explain it a little bit more. And that's why they bleed, because, you know, normally when you cut yourself, the platelets go into action and form a clot, right? These guys, it takes a lot longer. So bear that in mind. All right. Think that's what I want to say about that. The big things in this chapter, I would say for you, from the perspective of things like exams and HESI, warfarin, Coumadin, the levels pertaining to those two, the side effects, the antidotes. These are all the things that you need to be aware of. Okay?
Okay.
All right. Trying to see if there's anything else I want to. On page 421, it talks about anticoagulation therapy and the considerations between heparin and warfarin. Okay. There's a lot of things that we need to bear in mind. Some of these drugs might need to be stopped before surgery. Yeah. Because obviously you're causing more bleeding. So potentially, again, it's that balancing act, but they may need to discontinue their meds, say, a day or two before surgery, depending on what's going on. So that might be a teaching point. And again, talking about the foods that they can and cannot eat. And yeah, other things as well. Think about brushing their teeth, bleeding gums, things of that nature, blood in their stool, blood in their urine. These would all be indications that this is too much, that this medication needs to be lowered, that the dose is too much, right? They may even see what is called petechiae. When you see petechiae, it's like tiny little red dots on the skin, but basically they're bleeding. You might actually, you know, they may bang themselves a little bit and they may have a huge hematoma or what's called ecchymosis, big areas of bruising. Anybody ever seen that on patients, especially the elderly? Yeah. So these are the types of things that you want to look for that indicate that this is that the anticoagulation is too effective. And let's see if there's any other things that I want to. Oh yeah, again, patient teaching. Even things like red pepper, by the way, garlic, red pepper. These can have an anticoagulant type of effect. So we want to make sure that the patient understands that these herbs that they think are great and doing what they should be doing, even turmeric. It says here, garlic, ginger, ginkgo, St. John's wort, all of those types of herbs can unfortunately have an effect on these anticoagulant meds and make the blood too thin. And, oh yeah, the foods, it may not say kale, by the way. It may say things like green tea. Green tea can have an effect. So it can thin the blood. So these are things that you want to be aware of. So just trying to see what else. Lettuce, any of the green sort of vegetables would be a concern. But green tea is involved in there as well. And I'm trying to think if that's been on a test. It usually says leafy green vegetables somewhere in that piece. So what I'm saying to you is if it says something like along the lines of, would the patient eat an egg, leafy greens, and green tea, would that be an issue? Yes, that would be an issue. That would potentially upregulate vitamin K and stop that anticoagulation effect. Does that make sense? Any questions on that? That's a lot, isn't it?
Yeah.
Yes, that's a lot. That's a lot of information.
I know. But thankfully, you have this recording. and that'll be helpful. So listen, it's 3 o'clock. Do you want a 5-minute break?
You said we were
Yes,
gonna go over
please.
something about the exam.
Yeah, I do. Well, you know what? We only have one chapter left, and I think, I'm going to be there tomorrow, so we can go over the exam tomorrow. I'd like to finish this lecture off.
Please.
The reason being that way you've got all of this information that you can listen to again and again, yeah?
Yeah.
And then tomorrow, we will talk about exam 2, and we can go into more detail about this as well. You'll have time to absorb this a little bit, and that way you can listen to it again. It will take a minute for this to download, because this is like 3.5 hours, so it's going to take a lot to download. Hello, someone's got their hand up.
It was me, DeQuisha. So for the repeaters, will the exam review be recorded?
What do you mean?
Because we're not in class on Friday. What is tomorrow? We're not in class tomorrow.
Oh, you're not in class tomorrow. Let me think. Maybe
like you did the last time.
Right.
Recorded.
Yeah, I might be able to do that, actually. Remind me tomorrow, please.
Okay.
Because I can just do this. I can just, put it in. I didn't realize this. I forgot that some of you are not there tomorrow. But yeah, I can do that.
Okay, thank you.
You're welcome. Okay, we're on the home stretch, guys.
Oh.
Woohoo!
Are we taking?
Do you want to take a 5-minute break? We can. Let's take a 5.
Yeah.
Okay.
Thank you.
That's for me.
Did she say anything about when we're going to make up the quiz that we were supposed to do today?
I think Monday.
Oh, okay.
Tomorrow or Monday. You guys won't be there tomorrow.
Right.
Yeah, so we can't do it tomorrow.
We have class for her on Monday.
Yeah, Monday and Wednesday.
Yeah, so you may have to give it to us Monday when everything's there. So you may want to ask her about it.
Okay.
We have an exam as well.
Okay.
I think one of you asked about the quiz, or somebody asked about the quiz, right?
Yeah.
Yeah, it would have to be Monday, as I say, because a couple of you are not here on Thursday. So have to make it Monday. Just get my water. So now you're all going to want to do this from home, aren't you?
Me, I will. I can't speak for everyone.
No, it's not gonna work for me. I'm too distracted. My son is a mess.
Yeah, I think a lot of people feel that way, that it does cause distractions, for sure. But you've done well hanging with me today with this. It's a lot of chapters that we've gone over, but it's been fairly, you know, we've chunked it. And oh, just FYI, guys, on page, I'm going to put it here, 424. I want you to know these anticoagulant levels. Oops. Help if I could spell.
In the yellow box.
Pardon?
You said the ones in the yellow box?
Yeah. Yeah. Mainly, honestly, it's going to be the PT and INR. It won't be the APTT. But bear that in mind, and that is the therapeutic level right there, between 45 and 70. But I don't think you're going to get asked that, or probably be the PT and INR more than anything. Okay, I do want you to know those. And okay. Mercedes, someone's giving you food. Oh, is that your? Oh, you got your food there. Yeah.
I'm trying to stay awake. It's the rain. It's just
Mhm.
it's being at home. All of it's just coming down on me.
It's that cozy. It is that. I've actually got to teach again in a couple of hours, till 9 o'clock tonight. So.
Online?
Mm-hmm.
Oh, Lord.
And then it's cold in my house, and then I got this warm blanket. I'm just like trying to stay awake.
I have a question for you.
Yes.
If we're not going to be here in this class the rest of the week, does this mean, according to the schedule?
What do you mean?
If you look on the schedule, it doesn't show that we're in this class tomorrow.
She's gonna come in on Mrs. B's class, right?
Yeah. I'm sort of a clinical helper for Miss V's class, so I will see you tomorrow.
Oh, okay. He probably thought you meant we were in pharmacology tomorrow.
Is that what you meant?
Yes. So, so my question is, when are we going to be taking the quiz? And if it's pushed to next week, does this mean that we have a quiz on Monday and then a test on Wednesday?
Yes.
Ooh. Ooh, y'all don't have a weekend. Weekend is closed.
Yeah. Well, believe me, I would have loved to have given you guys the quiz today, but I have no way of proctoring 30 students, 30 plus students. That's the problem. So yes, it will be the quiz Monday and exam Wednesday. Yeah.
Oh, Lord.
I know. All right, let's get this done. So lipids, cholesterol. Now, talking of knowing your levels, one of the things I do want you to be aware of are the normal cholesterol levels. And that is on page, and I'm going to put it in here, page 440. Okay, the normal cholesterol levels. I do want you to know them. So serum cholesterol, 200 or below, triglycerides 150, HDL above 60, and LDL below 100.
What page is it?
440. I put it on the chat for you in there. Okay. And we've got two sort of things going on here. We have triglycerides and cholesterol. So while we sort of lump it all together, they are two forms of lipids in the blood. And by the way, I just want you to be aware of this. You do need cholesterol. You are aware of that, right? You need cholesterol. Cholesterol is the stereogenic pathway, and I don't know if I have a copy of this anymore. I used to have it on my other. But anyway, the bottom line is you have cholesterol, and then all of your steroids come off of that. So I'm talking about your hormones, all of those things. So you actually need cholesterol to make all of those things. So it's very important. It's just the ratios of what we're looking at need to be in balance. And that's the issue. And that can be part of the problem as to what happens when we get this buildup of fat in the vessels, atherosclerosis as it's known. And then the other issue that comes along with that is inflammation. Inflammation gets in there and unfortunately creates what is called, well, the macrophages get in there as a secondary to the inflammation, and they cause these foam cells. And it's these foam cells that can then break off some of this fat. The fat can travel down the vessel and cause a blockage. That's part and parcel of the issue that we're looking at. So we do want to mitigate this atherosclerosis and this coronary heart disease. So that's what's going on there. It talks a tiny bit about the foam cells and plaque formation on page 430. So what can we do about it? Well, you know, I'm just going as well with what happens with most of my patients. They don't want to be put on a statin straight away. I can tell you that. Nearly all of them are like, nope, I don't want to be on a statin. I want to try what? Natural things first. Okay, what does that mean? So we're looking at things like diet, exercise, yeah, lifestyle, those types of things before they want to be put on a statin. But we do have to be aware of the risk factors, and there's many of them when it comes to atherosclerosis disease, isn't there? So let's just have a look at some of the issues. One of them is called metabolic syndrome. Anybody ever heard of metabolic syndrome at all? No, metabolic syndrome? Okay, so it talks about it on page 431, and it's a combination of triglycerides being high, HDL being too low. By the way, when I'm teaching my patients, I always say, well, it's H is the high density lipoprotein, but I always say H for healthy. H needs to be high. And then the low density lipoprotein, okay? L for low, L for lousy is what I say. So that needs to be low. That needs to be lower. That makes sense. That might help you a little bit as well. So, but this metabolic syndrome is normally about 5 different issues. Their waist circumference is way too big. It's about 40 inches. Triglycerides are high. HDL is too low. Blood pressure is high. And also their glucose is high too. So, you know, there's quite a few pieces there that go towards making up this metabolic syndrome. So we really want to reduce all of that risk, reduce the risk of cardiovascular disease. So one of the big things that we do is we give statins, and they're called statins because they all end in statin is the name. So let's just look first of all at our little tiny case study. This final one here.